Again, we put on M mode, and this looks different than our previous seashore sign. So this is the stratosphere sign or the barcode sign. Basically, just like before, the top half one is just your muscles and your soft tissue where there's no movement. So they're a very straight line. On the bottom, you're going to see a very straight line as well. This can be challenging to see to the untrained eye. You can always use the patients as their own control. If you know they don't have a pneumothorax on the other side, then you can compare the two. So here's a comparison of the two beside each other. So here we're having the sandy shore, and here we're having the pneumothorax. And again, you can see how it's challenging to see which one's which. So if I don't see lung sliding, do I have a pneumothorax for sure? The answer is no. Here are all the other things that it could be, and so things to consider. In pediatrics, we don't tend to see as much of this as we do in the adult world, but still possible. So severe pneumonias, pleural adhesions, if they've had procedures like VATS or pleurodesis, if they've had pleural blebs, apnea, or you're intubated, you're not bagging, then you're not going to be having any pleural movement. If you have a main stem intubation, you might not see it on the other side. Any jet ventilation and severe asthma. So not all the time are you going to see lung sliding.
Severe asthma, but that's because there's a pneumo from severe asthma? Or?
No, because they're just so hyperinflated that you're just not getting any movement. Like think of those barrel chested, those like super sick asthmas that come in that are just not moving any air. So here we're going to see another lung. Keep an eye on the pleural line and tell me what you see. I heard lung points. Came from somewhere. So lung point coming in right about here. So you can see no movement, no movement. All of a sudden we have lung sliding. So the great thing about lung point is it is 100% specific for pneumothorax. This was shown in one of the papers, but later on we have found that blebs can cause this. Small pneumothoraxes trapped by hemothorax can cause this. If there's posterior pneumothorax, pericardium or loculated pneumothorax or pneumomediastinum, you might also see this. So there's your lung point. And the right clinical contact is very specific for pneumothorax. So this is what I was talking about before, about stopping and listening. So you need to stop on each rib space to actually look for pneumothorax. In this video, can you tell me if there's pneumothorax or not? Too fast. I have no idea. I can't see, is there actual lung sliding? Is there not? No idea. So you really have to stop on each one and take a good look. Versus here, you can see how we're stopping and you can see the change. So no lung sliding. The other trick is lung pulse. So this always, as we were talking about earlier, is a challenging thing for people. It is basically a mimic of lung movement because of the heart. So when the heart is beating, so specifically more commonly on the left side, you're going to have movement of the pleural line from cardiac reverberations transmitted through the chest wall. Blood is pumping through the vessels in this not ventilated lung, which can cause a small rhythmic movement, and it's going to be very rhythmical and always with your heartbeat. So one way to tell is that if you have the tracing on your ultrasound machine to tell you when the heartbeats are, if you're feeling for the pulse, you're going to see the same line over and over. So here, 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 here. Can you appreciate the change, like the little shift in the line? The farther that you go away from the heart, the harder it's going to be seen. You see this a lot of the time with hypoventilation. So if you're not ventilating the patient, you're going to be able to see this. So if they have a main stem intubation or atelectasis. So this is another picture of lung pulse. It's very hard to see on the video. It's easier to see here. So on the right-hand side, had to think about that. So this is actually a lung point that you're putting M mode on. So this, I think, is near what you were talking about earlier, where you're seeing the sandy shore and then you're seeing barcodes. This is actually when they're breathing and you're moving lung point for your pneumothorax. So the area of no pneumothorax to the area of pneumothorax. And then here, this is lung pulse again. So this one's a lot more obvious. So the regular rhythmical movement for lung pulse. So we're going to go on to case 3. So this is a 5-year-old female who fell from a 2nd-story window. She's tachypnic. She has DSATs of 91 on room air. She's got good air entry bilaterally and no work of breathing. This is what you see. What do you guys think? Pulmonary contusion. Why do you think that? Lots of B-lines, absolutely. So in terms of this child, she deteriorated throughout her stay. She ended up requiring CPAP and was admitted. So you can see all these B-lines coming down. Again, the B-lines going from the pleura all the way down off the edge of the screen. Here's another example of a pulmonary contusion. So lots of B-lines coming down. So the great thing about doing POCUS versus an X-ray for this type of thing is you can actually see these B-lines on POCUS before they are seen on chest X-ray. So you can see normal on the right and abnormal contusion on the left. So that was the tip and trick. You can see it on ultrasound before chest X-ray. So our final case, this is a 7-year-old female who is in an MVC, has a seatbelt sign, she's tachypnic and had increased work of breathing. And here's what you see on your scan. What do you think? Hemothorax. So fluid at the base of the lung in terms of trauma is hemothorax until proven otherwise. In terms of this child, she had a chest tube placed that drained 500 cc's of blood. She stabilized and was admitted to the ward. So here we're using our linear transducer to see the hemothorax. So you still could use a linear transducer, but you're already going to be using your phase array for your abdominal exam. So it's just easier to already be using that. But you could do, like I said, you could do the linear transducer and you could look on the left, the anterior axillary line or mid axillary line on both sides as well. So in terms of what probes to use, most commonly, you're going to already be using your phase array and or curvilinear doing your abdominal component of the EFAST. And so it's easiest just to look up when you're already in the right upper quadrant, left upper quadrant. Just rock up into the chest or slide up and look at your lungs because you're already going to be seeing them.